Ladies and gentlemen, it is indeed a great honor for me to have been asked by the Deputy Vice-Chancellor of the University of Johannesburg, Professor Angela Park, the Dean of the Faculty of Humanities, Professor Rory Ryan, and the Director of the Center for Social Development in Africa, Professor Laila Patel, to deliver the 2010 Helen Joseph Memorial Lecture. Delivering this lecture is a great honor for me in a double sense. First, I think, is the humility that one feels when reading about the principled and dignified struggles against injustice that were put up by individuals like Helen Joseph in this country, and the sacrifices that they had to make in their personal lives, about which we heard from, not just a few minutes ago. Second is the admiration and respect that one has for a people and for a movement that was able to put an end to one of the most unjust and cruel political systems of the 20th century, and to build in its place a system and a society that is democratic, inclusive, and respectful of the human rights and dignity of all South Africans. I realize, of course, that the road to a democratic and equitable society has not been smooth, that there were roads that were not taken, that global orthodoxies in terms of determining economic and social policies could have been questioned, orthodoxies could have been questioned and not emulated, that deep-seated inequalities could have been much more forcefully tackled to make democracy more meaningful for the majority of South Africans. But your achievements, nevertheless, inspire many other people and many other movements around the world who are struggling for democracy and human rights, including people in my home country, Iran, where an undemocratic, unaccountable, and illegitimate government uses very brutal methods to suppress all manner of opposition, while forcefully imposing what in Iran is referred to as gender apartheid, apartheid cinsiyati. Yes, the ugly term apartheid resonates with many Iranians, especially Iranian women, who draw parallels between pre-democratic South Africa and their own current predicament. In preparing for this lecture, I have been asking myself what Helen would have thought about the subject of our lecture this evening, caregiving. For someone who was involved in the big political struggles of her times for justice and democracy, would the issue of care have been too soft, too uncontentious? My answer to this question is negative. I think Helen, as a social worker and as an activist of the women's movement in this country, who had a particular interest in the quality of welfare services, would have been very supportive of the kind of issues and demands that we're going to talk about tonight. And I look to those of you who knew Helen very well for confirmation of my hunch. I'd like to argue that the subject of our lecture, care, is central to the struggle for equality and social justice. I would like to argue that care is fundamental, in particular, for gender justice. And it is an issue that needs to be addressed head-on if we're really serious about addressing the grotesque levels of inequality that exist, both between countries and within our societies. To make this argument, I'm going to try and deliver 3 points tonight. First, I'm going to argue that caregiving is as fundamental to the economy as it is to society more generally and to people's level of well-being. Second, I will suggest that while everyone should care about care, not everyone does, that the burdens and costs of policy neglect fall very unevenly on different members of our societies, whether it's in terms of gender, or socioeconomic background, or region, or other inequalities. The third part of my argument is that if we continue along the present trajectories, caregiving itself will become one of the factors and one of the mechanisms that feeds into growing inequalities. Hence, the analysis of gender and care needs to be contextualized within the larger picture of the causes and consequences of social inequality. I will conclude the lecture by suggesting that far from being a kind of motherhood and apple pie issue around which everyone can rally, the issue of care is deeply contentious, and that women's movements need to play a much more proactive role in bringing care out of the private arena and making it an issue of public debate and public policy. They need to advocate far more forcefully for this, and far more forcefully in favor of public support for both paid and unpaid forms of care, and to ensure that the costs of providing care are more equally and evenly divided among all members of society. To be able to do so, women's rights activists need to form coalitions with other groups who are struggling for equality and justice. So let me begin with the first point, which I labeled care as a bedrock of social and economic development. But perhaps first it's good to explain what we mean by care. Care is commonly thought of as the activities and the social relationships that are involved in meeting the kind of physical and emotional needs of people, of children, of adults, many of which are structured by relationships of kinship and family and friendship and community, and carried out on an unpaid basis. This is clearly one central component of what we call the care economy, and is frequently referred to as unpaid care or unpaid care work. It includes, very more concretely put it includes things like basic housework, doing the dishes, making food, shopping for groceries. But it also includes relational aspects, the person-to-person aspects of care. Looking after a child, giving a bath to an elderly person who may not be able to do it themselves, taking an ill person, a friend or a neighbor, to the nearest health clinic, accompanying them to the clinic. It is a highly feminized domain. The bulk of this work is carried out by women, even as women, at a global level at least, are increasing their participation in paid work, in employment. But it's also a very invisible domain. It's not counted as part of the GDP, and it's invisible in the kind of representations of the economy that policymakers use to design policies. But when it is counted, when this kind of work does get counted, and there are methods for doing this, it becomes clear that unpaid care constitutes a significant share of the GDP. Debbie Budlander's calculations for South Africa, which were done as part of the project to which Leila was referring, suggest that unpaid care work is equivalent to something between 11% and 30% of the GDP in South Africa, depending on what type of measure is used. In a context that is more equal, that the income inequalities are lower, and taking the case of Switzerland as an example, in such a country where care work is valued within the pay scale on a higher level, the percentage will be even higher. In Switzerland, for example, there were very careful calculations done by the researchers on the UNRISD research team. The unpaid care work in Switzerland was larger than the insurance and banking sector in Switzerland. And as you know, Switzerland is known for its insurance and banking. It's a big part of the economy. But the unpaid care work in that country is larger than those two industries put together. So it's a huge part of our economy. However, in addition to this unpaid care work, many of the intimate tasks that we associate with care do tend to slip out of the unpaid domain of family and community and kinship and go public. Whether it's in the market, or in the state, or in the voluntary sector, the not-for-profit sector. These paid care services include the work of childcare and elder care workers, nurses, teachers, as well as domestic workers. In many countries, these workers are a growing part of the workforce, especially of the female workforce, as Leila was mentioning earlier. Many of the nurses and the teachers, a huge percentage of them at a global level, are women. And this type of employment is becoming a more significant share of the entire workforce globally. In a highly developed country, developed in quotations, like the United States, for example, professional and domestic care services have grown from employing something around 13% of the workforce in 1900 to something around 23% in the late 90s. In countries with relatively high levels of income inequality, like Brazil in Latin America or South Africa in this continent, domestic workers already constitute a significant share of total employment. In Brazil, it's something around 18% of the entire female workforce, and in this country, it's something around 16%. When care work is decently paid and socially protected, it can meet the interests of both workers and of the users of those care services. But this is not often the case. Now, having explained what care is, let me try and turn to the main question of this first part, which was to try and say why we should care about care. Now, it doesn't take very fancy econometric models to show that the time and effort that people put into taking care of others constitutes a key input into the well-being of not only children and frail elderly persons, but also of able-bodied adults. But many economists who were and still are busy building very fancy models seem to have missed the point until feminist economists started raising the issue. Our human condition is indeed one of vulnerability, frailty, and dependence. We're all care receivers for much of our lives. Care is not something out there that we only do for infants and orphans and very sick people, although that is a very significant part of care work. We are all recipients of care and therefore dependent on well-functioning care systems, which typically include both public and private elements, both paid and unpaid work. This does not, however, mean that as citizens we can easily agree on a set of principles and policies for care. It is particularly difficult and challenging to agree on a common set of principles and policies in contexts where socioeconomic, racial, and ethnic inequalities are very large. I will return to this point a bit later. But what I do want to emphasize for now is that from the point of view of the so-called policymaker, whether it's at the national level or global level or subnational level, there are also very powerful arguments and reasons for being attentive to care. The American feminist economist Nancy Folbre has made very persuasive arguments about seeing care in general and care for children in particular as a public good. As she put it recently, half mockingly, in a New York Times economics blog, parents aren't just raising adorable kids, they're also producing little human capital units of their own who are likely to grow up, get jobs, pay taxes, and again raise little human capital units of their own. Hence, you need policies that can support them in doing so, not only out of concern for those children or their parents, but also if you're a hard-headed economist who wants to have productive workers who pay taxes and contribute to pension funds. In other words, you need to make sure that labor is produced and reproduced. You need to see labor as a factor that needs to be reproduced. Now, if policymakers aim to nurture growth and structural transformation of the economy, then it becomes imperative for them to reproduce a healthy and skilled workforce that's capable of learning and creativity. But what it takes, it's not just building schools and hospitals and meeting targets in terms of X percentage of children enrolled in school, or Y percentage of children who achieve passes in the final examination, although that is clearly an important part of the struggle and of what is needed. It's also about creating economic and social conditions that facilitate caregiving, whether this is by a carer who is a nurse in a public hospital, or a preschool teacher in a community school or community creche, or a domestic worker who works in a private home, or indeed a parent who is caring for her or his children while trying to meet the basic needs of her family, of earning a living. Now, situations where those who are lucky to find paid work have to put in extremely long hours for a wage that can barely meet their own basic needs and that of their dependents, while many others are not even lucky to find work and face insecurity, face unemployment, loss of hope and self-respect, are not conditions that are very conducive to parenting and caregiving. The provision of care for children, as Diane Nelson points out, is a very exacting task. And the cultivation in children of a sense of ethics, of citizenship, an ability and desire to communicate with others, to be good citizens, is not just it's not easily undertaken by adults who themselves feel that they have been denied social justice and excluded from a normal society, their aspirations to a decent job and decent home dashed. What I'm therefore trying to suggest here is that care should be used as a lens through which we question and interrogate our broader policies and broader structures to see if they're facilitating or hampering caregiving. What's happening to care and well-being in the process of what we call economic development? How does economic development affect household structures, patterns of employment, and family formation? And how do these in turn affect care? Rather than kind of assuming a priori that development or economic growth will lead to an improvement in caregiving and human welfare, macroeconomic policies and development strategies need to be scrutinized with regards to their impact on care. Do people have time to care for others and for themselves? Do they have the resources and the other preconditions that are a necessity for caregiving to do so? Now, the answers to these questions cannot be found in the national rates of economic growth or in the stock market indices that we seem to be very worried about. Indeed, producing very high rates of economic growth can come at the expense of the time that is necessary for caregiving. Let me now turn to the second part of the lecture, which I've called Care Gaps and Care Burdens. Who pays, who cares? Now, if, as I've been suggesting, both citizens and policymakers have an interest in seeing a well-functioning care system, is this actually being reflected in our actual policies and institutions? Is everybody chipping in time, effort, and money to support and sustain the care system? Now let us imagine the care system as a care diamond, as we've called it in the UNWIS project, or a care mix, as Mary Daly and Jane Lewis refer to it. The notion of a diamond, with its 4 angles, is meant to draw attention to the diversity of strategies, institutions, and practices that are involved in the design, the funding, and delivery of care. With households and families in one corner, markets in the other, the public sector in the other, and the not-for-profit sector as the fourth corner. Now, the boundaries between these different institutions of the care diamond are neither clear-cut nor static. They change over time. It's also very difficult to draw boundaries. Governments, for example, often partially subsidize and sometimes regulate provision through markets and through the not-for-profit providers. Similarly, when public services are insufficient, the provision of care by households very often increases to meet the need that's there and the demand that's there. The state in particular plays a qualitatively different kind of role from other institutions in our care diamond. Not only is it a direct provider of care, but also it's a key decision maker in the overall design of the system. Sometimes it does this through explicit actions and policies. At other times it does it through inaction, letting the burden be taken up by others and by other institutions. Rather than being a very well-coordinated and solid system, which the idea of a diamond suggests, what we find in most countries is a very fragmented, very uneven care net with lots of gaps and very big holes. Now, much of the burden of care historically has been assumed by families and households, which is a rather polite way of saying that most of the caring has been done by women, with others free riding on that work. And this continues to be the case to this day. We know from very detailed and meticulous analyses done of time use surveys, including those that Debbie Budlander did for our project, for the 7 countries that were included in that part of the project, we know that women perform the bulk of that work. And now we have very good statistics to show that. It's not just what we thought and our impressions. We have data to show it. In many countries, they do this in addition to earning an income. And overall, this adds up to give women a longer working day than men. Again, in all countries for which we have data from our project. And we know that the trend is the same at a global level, the data that has been produced by others. In general, men have been more likely than women to default on their obligations to their kin, including their own biological children, leaving both dependents and those who care for them in a vulnerable position. And in some ways, we can see the emergence of the welfare state in some parts of the world coming earlier, in other parts coming later. We can see the emergence of the welfare state as being an effort to partially compensate for that, to partially socialize care for dependents. Now, whether you're thinking of liberal capitalist economies such as those of the UK in the 1950s and 60s, or if you're thinking of kind of developmental states like that of South Korea in the 60s and 70s, the reliance on families for providing day-to-day care was the order of the day. This was so even though in a country like Korea, the large corporations, the chaebols, they assumed a minimal welfare function for their largely male workforce. And in Britain, the National Health Service may have taken some of the burden of care off the shoulder of families and households. But nevertheless, families were, at the end of the day, the ultimate safety net in both contexts. Now, this situation has changed somewhat over the past decade or so. And most welfare states in the advanced industrialized countries have increased their spending on care and on family. And this has happened partly in response to the demands of women's movements in those countries, partly because assistance was needed in order to persuade families to have children, because there were fears about very low fertility in some of these countries. And it was partly in order to adjust to the reality that a lot of women did not have anymore the kind of time that they had on their hands previously, because they had, in large numbers, become part of the hitherto male workforce. They were working for wages and had less time on their hands. However, what is perhaps important for us to retain from the experience of those advanced industrialized countries, about which a huge literature exists, is that despite their rather similar levels of economic development, the welfare regimes across these countries differ significantly in terms of both the overall spending that they allocate to families and to care, as well as the way in which they make that spending, how they spend that money. Some states, for example, the Nordic countries and France, have placed the accent on the provision of public care services. Other countries, in particular the UK and Ireland, for example, have spent more on cash benefits. Countries like Germany and the United States, on the other hand, have spent more on tax breaks for families, rather than on service provision, which has tended to favor higher income households. So the Nordic countries have been called caring states, and states like the United States, Canada, and Southern Europe, which tend to do less, are often referred to as non-caring states. And these spending, levels of spending, as well as ways in which spending is done, have significant implications for child poverty, as well as for the poverty risk of households, especially those in which women, mothers in particular, have to juggle both earning an income and caring for dependents on an unpaid basis without male support. And I understand from the work on South Africa that this is a particular problem in this country as well. Now, some people have argued that developing countries are invariably characterized by what is often called in the literature having a familialistic welfare regime. which basically what it means is that they assign a maximum of welfare obligation to households and families. However, the project that we were carrying out with our colleagues, which focused mostly on developing countries, challenges the view that only more developed countries can afford care provision by the state and market, while poorer countries have to be condemned to relying on unpaid family and community solutions. Specialized care services, for example, elderly care and creches, may be underdeveloped in many developing countries, but we would argue that a wider range of policies influence and shape the care that is often assumed. They're assumed and they're not problematized. One is the availability of paid work, or in its absence, some kind of social transfer that can ensure that households have sufficient levels of income to purchase the necessary inputs into direct caregiving. The second assumption, which is not problematized, is having appropriate infrastructure and technology. Basic things like piped water and sanitation, domestic technology, that can reduce the burden of unpaid domestic work. The third precondition are enabling social services, basic social services, and I'm not here talking about care services only, but basic services like primary education and healthcare, to complement the unpaid caregiving that is done by families and households. Now, none of these three preconditions can be assumed in developing countries. Hence, investments in basic infrastructure, such as piped water, can be seen as a highly productive input into the care economy. Similarly, investments in the public health system, in the pay and working conditions of nurses and home-based care workers, are also highly productive investments in the care economy, which reduce the burden that is placed on the shoulder of families and households. Similarly, having a decent and regular income is an essential input into the care economy, whether this comes through paid work or through some kind of regular and reliable transfer or grant. Having ample time on one's hand is not sufficient for caregiving if you don't have the resources with which to purchase the food and medicine and clothing and the services that are needed to get to a health clinic, like transport. Now, middle-income developing countries, such as South Africa, Argentina, Chile, Mexico, Uruguay, they've all been experimenting also with a range of care-related, more specific care-related social policies. This includes early childhood education and care services, for example, conditional and unconditional cash transfer programs, and home-based care programs for sick and for elderly people, just to name a few examples. And all of these countries also are characterized by relatively high levels of income inequality, much higher levels of inequality than the developed countries. The challenge they therefore face is not only to expand coverage of some of these programs, but also to do so in a way that reduces class and other inequalities. And this becomes in particular a really formidable challenge when we use a mix of public and private provision. Let's just to give you a couple of examples. Think of the health system in this country and the resources that go into the public health system per user compared to the resources that go into the medical insurance-based schemes. According to data that was provided in the reports that Frans Seelund and Debbie Budlander produced for our project, the medical schemes in this country spend an average of about 8,800 Rand per beneficiary, compared to the public sector spending of 1,050 Rand per person. Now, this is quite a significant level of inequality, and I understand that public health expenditure has increased in this country, but still, this is quite a significant gap. To give another concrete example, we can turn to preschool education and care. Now, inequalities in terms of social class and regional differences in access to preschool education for 5-year-old children, for example, have been reduced substantially in one of our other project countries, Argentina, which made the policy move of making enrollment mandatory for children at this age group, and also expanding public services to meet the demand. However, for younger age groups, where public provision is still limited, and where the market plays a very dominant role, enrollment rates for children from lower income households remain a tiny fraction of the rates for children from higher income households. Since low-income countries, households cannot afford private childcare, they face very long waiting lists for the very few public creches that exist, and often as a result have to rely on less reliable and less professionalized so-called community services, or on unpaid care by family members, and in some contexts on just letting children care for themselves. Now, while higher income groups usually have a range of options, such as private childcare, as well as hiring domestic workers, the ability of lower income households to purchase care is very limited. It's therefore very difficult to talk about equality of opportunity when both children and their family carers, be it a mother or grandmother or father, when in situations where they face such different care options. Middle-class children are provided with good quality care services that facilitate their growth and flourishing, that ensure that they do better in school when they are in school. And their carers have the option of holding on to stable employment and having a double an income where two people earn in that household. Among the poor, on the other hand, care has to be foregone, as family carers seek irregular and unprotected paid work. In other words, those who have economic advantages in other realms are able to purchase more and better care. As a result, those economic inequalities in the sphere of economic inequalities spill over into care inequalities, creating vicious circles of inequality. The following quotation from the study of India, which was one of the other countries in our project, I think captures this quite well, and I'm quoting here. Among the poor and laboring households, where mothers are engaged in paid work in or away from the home, and where other kin are not likely to be present, childcare is abbreviated. The high infant and child mortality rates among the poor are blamed on their ignorance and their negligence of their carers. But for laboring mothers and fathers, however, the lack of paid work or of adequate wages and livelihoods is the reason for the care deficit. They do not see how care is possible without the wherewithal for subsistence. In contrast to this, an enhancement in familial time and quality of care is possible at higher income levels and is also demanded by the changing ideas of childcare among the elite and the middle classes. Constant adult attention, indeed a surplus of care, and multiple organized activities are seen as modern, progressive, and an investment in the child's future. The low-wage domestic workers are often the ones supplementing this expanded familial time in elite households with a deficit of care in their own homes. Let me now turn to the third and last part of the lecture. When we look at countries that are worlds apart, which was the title of the lecture, developing countries of Africa, Asia, Latin America on the one hand, and the advanced industrialized countries of Europe, North America on the other, there are both commonalities and differences in care arrangements and in policy tendencies. However, in a period of notoriously rising income inequalities, care arrangements within the same country, indeed even within the same city, also turn out to be worlds apart. While care itself, as has been suggested, becomes one of the drivers of growing inequality. Now, the dividing line between the North and the South, or the developed and developing world, has become, some would argue, somewhat blurred in recent decades. The kind of financial liberalization, regressive tax policies, labor market policies that are aimed to make labor more flexible, all of these have generated a number of common global trends and common global problems. This includes, for example, the increasing prevalence of informal work, recurrent economic crises and financial crises, which now also afflict the developed world, and increasing levels of income inequality. Now, one common challenge that confronts many countries, wherever they are, is the growing inequalities in the quantity, quality, and choice of care arrangements. Now, while in recent years, greater attention has been given to social issues and to poverty, a lot of the global debate claims to be about poverty, in actual fact, very little has been done to address these notoriously high levels of income inequality. And in fact, very often, the growing levels of inequality have been justified by referring to the mantra of equality of opportunity. It's unfashionable these days to say that inequality is increasing by showing the income inequalities. These are inequalities of outcome. It's claimed that inequalities of outcome doesn't matter as long as equality exists at the level of opportunities. But these imbalances that exist actually fly in the face of any notion of equality of opportunity. In a world where elites can satisfy their care needs by hiring others, domestic workers, nannies, therapists, etc., and by accessing fee-paying creches and homes for the elderly, while the majority have to rely on underfunded public services that are stretched and overstretched kinship and family networks, opportunities for human development are also as unequally distributed as income is. But what is also even more depressing is that in these very unequal contexts, it becomes very difficult to construct alliances around common human needs and around common principles and common policies for care. Another common trend which has been associated with globalization and with neoliberalism is, of course, the changing role of the state in financing and regulating and providing welfare services more generally and care services and care giving more specifically. There have been many efforts to make states behave more like profit-making entities by raising user charges and rationalizing staff time. In addition, many of the functions that so far were carried out by states have been outsourced, as the term is, to non-state entities, whether it's private, for-profit, or not-for-profit organizations. In many developing countries, many of the social programs that attend to care needs would not function without the participation of these community-based and non-profit organizations. Many lower-income countries in particular have also come to rely heavily on voluntary, or what is called community work, even for the direct provision of public services. As the feminist economist from New Zealand, Marilyn Waring, recently said about outsourcing to community in New Zealand, and this could be applied in any other context, as she said, we know that community is usually mom or daughter or auntie or neighbor or some other woman who already works 16 to 18 hours a day. Sometimes she's in the paid workforce, sometimes she's not. Now, the attraction for governments to partner with non-for-profit organizations to provide things like care is understandable, given that the public subsidies that they frequently provide for these organizations are only a fraction of the full cost of care provision, of what it would have cost the state if it was to provide the care itself. But there is a limit to how much care workers in these other organizations can absorb the costs through self-exploitation without negative implications for their own health and well-being, and also, in the longer term, without negative implications for the quality of care that they're able to provide for their recipients of the services. And this is, again, a common trend, as we said, across countries. This provision of services through for-profit and not-for-profit organizations, and which raises a set of common challenges. A third common feature across these regional and developmental divides is the prominence of families in all their diverse forms in meeting care and welfare needs. This idea that familialism was something of the past and now there's much more division of responsibility is something that needs to be questioned. Familialism is neither a relic of the past, even in Europe, nor is it a feature that disappears with economic development. Nor can we assume that there's a linear process in which responsibilities are shifted from families to the state and and the market and other actors. As the recent decades have shown in countries where the state was assuming a greater responsibility, and here I'm thinking of countries, post-socialist Eastern European countries and China, there can be regression, and there, in those contexts, there has been regression, with the burden falling back on families. Now, I've just highlighted 3 common trends and common challenges that countries around the world face. Now, despite these common social and economic trends and the global circulation of policy blueprints, the processes that have been associated with globalization seem to have increased and not decreased. Income inequalities also among countries. After more than 3 decades of policies which have made the world a more integrated place, at least for global finance and for the elites who have been policy shapers, in fact, income inequalities among countries remain large and have increased, not decreased, contrary to what globalization's very noisy advocates predicted. Global inequalities in income and power have also been an important impetus for the movement of people across national borders. Included in the streams are many women and some men who engage in paid care work. Domestic workers, nannies, nurses among them. Now, a lot has already been said about the economic pressures that have pushed many women, and many of them are very highly educated and qualified women, to leave their own children and family behind, to leave their own jobs, sometimes as teachers, nurses, or university professors even, in order to take care of the children and the elderly in the richer countries. Now, in contrast to domestic workers who are considered to be unskilled, in quotations, and whose migration and employment very often is undocumented and unregulated, nurses are defined as being part of the skilled workforce. Both their migration and their employment are more intensely regulated not only by governments but also by professional and labor organizations in both host and sending countries. However, beyond the individual nurse and her family who may benefit from the higher earnings, the major benefits from nurse migration go to the health systems of the destination countries. The costs, however, are largely borne by the healthcare system of the country of origin, of the country at the other end of the global nursing chain, as it's called. As it has been repeatedly pointed out, health worker migration has adverse effects on healthcare provision in many poorer countries of origin. The costs extend beyond the loss of investment in education and training, which was done with public resources, to include also depleted health services and health systems. And such deficits are particularly stark in low-income African countries, which are also at the same time coping with the additional care burden associated with the HIV pandemic. Overall, then, there is some benefit yielded to the sending country and individual households, perhaps, by the remittances that are sent by the individual migrant worker. But it cannot be confidently declared that nurse remittances counterbalance the wider economic and social losses that result from that migration. The global migration of nurses can therefore be seen as yet another factor that feeds into this vicious circle of inequality, but at a global level, pulling the poorer and less powerful countries even further apart from the destination countries that are able to offer resources and have the power to attract and absorb this kind of skilled workforce. So let me draw the lecture to a close with a few concluding remarks. What I've suggested is that even though we're all frail human beings, dependent on receiving care, and even though we share an interest in having well-functioning care systems, the burdens and the pleasures of caregiving are not equally borne within our societies. As Diane Nelson has put it very nicely, the fact that much unpaid work, especially unpaid care work, is done for love does not mean that we always love doing it, but the fact that unpaid work is frequently burdensome does not mean that the best policy is to reduce it to zero. Women, particularly those from lower income households and marginalized social groups who cannot hire help or rely on accessible and good quality services have tended to assume a disproportionate share of this burden. They have assumed a disproportionate share of the work that's involved in reproducing our societies. This is clearly unjust. If we recognize and value care as the bedrock of social and economic development, then we need to respect the rights and the needs of both caregivers and care receivers. In such a context, ideally, all care receivers should have affordable access to care, as well as choice and control over how any help or assistance necessary to facilitate their independence is being provided, an issue that has been raised in particular by the movement, the disability movement. Unpaid caregivers would also have to be able to care in ways that strengthen the well-being and capabilities of the ones that they're caring for, but without jeopardizing their own economic security. And the same can be said about paid carers. And caregiving would become a real choice, a real option, with adequate recognition and reward. Now, this is clearly an ideal scenario, and not one that we're very close to realizing. But I would like to end on a relatively positive note, after having mentioned all the negative and difficult challenges that we face in a context of inequality, of being able to construct a common platform. But let me end on at least a few more positive notes, thinking about some principles that we may be able to build upon. For many poorer countries, investing in infrastructure and basic social services is an essential step in reducing the burden of care. And this is something that is within reach in many countries. Ensuring an adequate and reliable source of income is another essential step. I know this is a big challenge in many countries in particular, such as this country, which are facing significant levels of, very high levels of structural unemployment. But it's important to emphasize that caregiving is not just about having time, it's also about having resources and income. There's also an important policy lesson about recognizing care workers and guaranteeing their rights. Caregiving is not just about unpaid caregivers, it's also about paid caregivers, as I've tried to emphasize. Policymakers therefore have a duty to shift, to at least lead the shift from a strategy that relies on market and voluntary provision of care that is of the most informal and exploitative kind, to one that nurtures professional, decently paid, and compassionate forms of care. This requires effective regulation and monitoring by states. But organizations of care workers and care users also need to be involved in order to build public confidence in such services and to sustain their financing. Non-profit organizations play an increasingly important role in the delivery of care services. But it's the duty of the government and of states to create clear standards on the rights of volunteers and other workers in these sectors. Health and safety at work, regular stipends, and other basic rights, and to recognize these workers as workers. Finally, I think this important issue of making care more visible in statistics and in public debates. Care, as we have said, has important features of a public good, whose contribution to society and to the economy extends far beyond the individual person who receives care. The costs of care therefore have to be more evenly distributed among all members of society. Left to families and left to markets, they may underprovide, both in terms of quantity of care and in terms of quality. So we have a common interest in making sure that adequate care and good quality care is being provided. In order to increase policy support for caregivers and care receivers, care must emerge from the private realm and become a public issue. An important step in this direction is to make care work more visible through statistics, as well as in public debates. For example, timely and regular indicators, such as those that are provided by time use surveys, are needed in order to monitor policy effectiveness in reducing and equalizing care burdens. And I have been very pleased to hear that in South Africa, where a first time use survey was carried out in the year 2000, now Statistics South Africa has agreed to carry out a second time use survey, which will allow a regular monitoring of what is happening in the care economy in terms of time that people put into it. So this is very good news. Now, given women's disproportionate role as both paid and unpaid carers, women's movements have a particular interest in ensuring that the costs of caregiving are more equally borne across society. They are well placed to take a leading role in alliance with other social movements who are also struggling for greater equality, to show the famous feminist mantra that the personal is indeed political, and to initiate a public debate on this issue, which continues to be, after all, a key arena for social and economic development and realization of justice and human rights. Thank you.